Well, hello everyone. Good afternoon. We welcome you in one of our webinars in a cardiac surgery for the Gulf Society of Cardiac Surgery. I would like to welcome my colleague, the panelist, Professor Firas Khalil, consultant cardiac surgeon, chairman of cardiac surgery, deputy of executive director of Heart Center at King Faisal Specialist Hospital and Research Center, Director of Robotic and Minimal Invasive Cardiac Surgery. Welcome, Professor Firas. Professor Riyad Tarzi, Professor of Cardiac Surgery and Chairman of Cardiac Surgery of Salman Al-Dabbous Cardiac Center from Kuwait. Welcome, Professor Riyad. And our guest speaker is Professor Natuka. He is the chairman of the Department of Cardiovascular Surgery at the Institute of the University of Paraguay. He completed vascular cardiovascular surgery and earned his PhD in the cardiovascular pathophysiology. Since 2000, he has been affiliated with the Institute of Clinical and Experimental Medicine, where he was appointed as the chair of the cardiovascular surgery in 2017. In 2018, he became the professor of cardiac surgery at the First Faculty of Medicine, Charles University. He has authored more than 180 peer-reviewed publications focusing on advanced heart failure and cardiac transplantation, mechanical circulatory support, and actively involved in several international and professional societies. Welcome, Professor Natuka, and thank you for your time. And we are all eager to hear from you.
Thank you very much, dear Chairman, dear colleagues, dear friends. It's my great honor to share with you and walk you through the saga of the LVADs as they have developed over the last 3 decades. I'm very happy that we can connect at least remotely at this time of hardship for some of the regions in the territory. And I'm very hopeful that the things will resolve very soon and we shall have more personal interaction in timely manner. So with that, let me share the title of my presentation, which is shown here. And this is our center at Prague, ICAM, Institute for Clinical Experimental Medicine. So here are my disclosures. So and indeed, as I've already acknowledged, it's pretty evident that over the last 2.5 decades, the field of the LVADs has dramatically changed and transformed from pusher plate, bulky, low durability devices such as HeartMate XVE over the axial flow pumps with bearings represented by the HeartMate 2 towards the latest generation of pumps on centrifugal principle and for a considerable period of time. So we have been left with the single device at the market, the HeartMate 3. So here is the principle of the HeartMate 3 operation. The uniqueness and the novelty of this device was in introducing the full magnetic levitation, which allows for very homogeneous blood flow path across the housing of the pump itself and eliminates any areas of stasis by adopting the artificial pulse. So we have been very fortunate and privileged that we had the opportunity to implant the patient 2 and 3 worldwide with the HeartMate 3 back in 2014. And I'm very keen to say that both these patients in our Prague cohort and clinical follow-up are still alive and doing pretty well. So here is a configuration of the HeartMate 3 device as implanted in the patient, sucking the blood from the left apex and pumping the blood all the way across the outflow graft to the ascending aorta. So obviously the pump is powered by the percutaneous cable as depicted here on this picture. I cannot start the saga of the HeartMate 3 without mentioning a landmark trial of the Momentum 3 study, which encompassed 1,028 patients who have been randomized between the latest generation centrifugal full magnetically levitated pump and the second generation axial flow pump represented by the HeartMate 2. And it's pretty clear that the primary endpoint has been met and was statistically significant in favor of the latest generation of centrifugal fully magnetically levitated HeartMate 3 device, as shown here, which also translated to individual components of this composite endpoint. Here we can appreciate that the risk, which was ominous risk of pump thrombosis, has been almost eradicated, as shown here. The same we can state about the strokes, which have been cut in half already in this initial randomized trial. And the same result has been also observed to lesser extent, but statistically significant in relationship to the gastrointestinal bleeding, as shown here. And if we take further down the road, the follow-up of these Momentum 3 patients, we can clearly see that the 5-year survival was in the arm of the HeartMate 3 was 60%, which was pretty unprecedented for any previous generation of devices. And importantly enough, so it's not only about the highly controlled randomized trials, but more about the benefit for the real patients in real life scenario. And the success at 5 years has been translated and replicated in the Elevate registry, which embraces European countries. And the same was the case for 5-year survival in the STS Intermex American registry in the patients who have been objectively at higher risk population compared to the controlled Momentum 3 trial cohort. Now for the first time, we have objective long-term data from the same American registry, the Intermex, at 7 years, which show that the median survival of the patient on the HeartMate 3 is now over 50%, which is very, very gratifying. And returning back to the 5 years data, I would like to highlight that the most of the benefit of the in mortality was in a cause of death reduction related to the hemocompatibility related adverse events such as thrombosis, stroke, or bleeding. And with that in mind, with almost eliminated the pump de novo thrombosis, ischemic stroke dramatically decreased. So we believe that the highest benefit for further improvement of our patients was at the realm of reduction of non-surgical gastrointestinal bleeding. So where we have sought to find opportunity, and therefore we joined forces in a global trial of the ARES, where we try to test the hypothesis that removal of the antithrombotic therapy represented by the aspirin may be contributing to the positive outcome, especially in terms of non-surgical bleeding. So it was clearly across the continents, global trial as shown here. And we have randomized 628 patients, and the primary endpoint is self-explanatory. So there was statistically significant reduction in the primary endpoint in favor of removal of the aspirin, so highlighting the higher degree of hemocompatibility with this particular device. And it was even more prominent with 33% reduction of non-surgical bleeding as here depicted as a secondary principal endpoint in this trial. More so, needless to say, that it was gratifying to see that this benefit of decrease in bleeding complications was not offset by any thrombotic complications as represented by thrombosis or stroke of any kind. And there was also no difference in terms of the mortality between these two cohorts, so which further underscores the safety of this strategy. Just to be a little bit more granular, let me just mention that we try to dissect into the roots of the success of this trial. And as shown here, I would like to mention that the time in therapeutic range in terms of anticoagulation with warfarin was 56% of time in range. So, and we could observe that each increment of 10% of the efficacy of the anticoagulation was associated with clear decrease in the adverse events as shown here. So, and with that in mind, so we decided to to find other better ways how to maintain the patients in more stable way in anticoagulation rate. So, and one of the ways is to increase with resource intensive vitamin K management intervention, or the other opportunity is in changing the drug in essentially and switching from warfarin to DOAC. So, and so far there have been three exploratory trials as depicted here. One of those was our Prague trial, HM3 trial, and both three trials have been already published, and the initial outcomes were very satisfactory, so which set a stage for further exploration in this respect. And we can state that despite the fact that there are some concerns and special therapeutic interventions in bridge to transplant reversal of the patients at the time of the transplant, we can state that early versus late use concerns can also be discussed. The practice change will require a well-powered randomized control trial, and eventually the clinical comfort will drive the practice change if possible. So, but and with that in mind, I would like to acknowledge that there is underway another randomized trial, which is called Switched. We'll be pleased to participate in Prague with this trial too. It's spearheaded by Neil Uriel at Columbia University, and we remain hopeful to provide the definitive answer for this question, whether we can safely switch to more stable drugs in HARMONY-3 patients. So to move further down the road, let me touch base on a hot topic of the net prolongation life with the LVADs as a complementary therapy to the transplantation. So what it stands for. So this is a strategy of implanting an LVAD in younger heart failure patients with the goal of extending their overall survival by delaying a heart transplantation, either temporarily or even in a long term. So essentially, or in other words, to delay starting the clock ticking of the transplantation and all the associated complications with the transplant, which is ultimately and of course a great thing for the patient, but it's also associated with substantial drawbacks. So, and to set a stage for that, let me show the data of survival at 5 years in LVAD patients in the population younger to 50 years, and it showed that the 5-year survival is 73% here. So, and if you take a look to the international registry of the transplant survival after heart transplantation, we can clearly see the same, very much the same survival at 5 years, even for the patients between the range of 18 up to 59 years of age. So, and this sets a stage for comparing and contrasting and trying to test an equilibrium between these two therapies. As from this data, it's pretty obvious that we have to at least raise the question whether the heart transplantation is an ideal first option for this younger generation. So, and with that in mind, let me highlight one more important fact. If you take a look to these curves, it's clear that the median survival in patients after the transplant between ages 18 and 59 is between 11 and 13 years. So, which makes it pretty clear that the redo heart transplantation may be required for most of these younger population patients. Nonetheless, the availability of the retransplantation is fairly low in all the registries, and it's associated with the heightened risk of complications and mortality. So, having said that, let me share the data of Professor Neil Uriel from Columbia. So, and this data has been presented in the last year. So, and basically, they sought to find the clue to this point, and they took all the patients from Columbia University implanted with the HeartMate 3, and these have been propensity matched with the UNOS patients' data. So you can see the survival at 2 years after before the propensity score matching. And if you take to the figure on the right-hand side, you can appreciate that after propensity score matching, so there was absolutely no difference in survival. However, we have to understand one important point. The clock does not start ticking at the time of the therapy, whether it be heart transplant or the LVAD, because the availability of LVAD is much easier, to be timed and determined, and the patients may experience significant complications or risk of death or delisting for worsening of their clinical status over the period of time of waiting. So for this reason, it's much more logical to start and compare these two therapies from the time point of either implant or listing for the transplant. So, and once doing so, if we take a look to this right-hand sided figure after propensity matching, it clearly shows that there is a survival benefit in patients implanted with the HeartMate 3 younger population compared to the patients since the time of listing for transplantation. So, and let me draw attention to some complications, of course. And if you take a look specifically to the figure on the right-hand side, the complications at 1 year show that there is definitely lower risk of renal dysfunction and borderline risk reduction in infection requiring hospitalizations. However, what has been observed was the borderline higher risk of strokes. Nonetheless, here I would exercise some caution in the HeartMate 3 patient population because the risk of stroke in this particular matched cohort of transplant patients was 0.3, which is kind of unprecedented. And this is something probably which is closer to the reality. We just not reached statistical significance. To provide you one more argument why we should consider the LVAD therapy as a first line for younger patients, let me spend a minute on the elasticity and plasticity issue. So with the progression of heart failure, we can appreciate that with the deterioration of the heart failure, the myocardium transitions from the elastic region, crosses the elastic limit to the plasticity region. So, and then we can speak about the full recovery or partial recovery. So as an equivalent of that, and one may argue to name it also recovery or remission of the heart failure. So, and there are well-known data which has been published already a decade ago that in non-ischemic, typically younger patients with recent onset of heart failure, there is up to 40% the likelihood of the weaning after the transplantation. So, and by choosing the first-line therapy of the transplant, so we are contriving these patients of the opportunity to be serially followed up and potentially weaned from this kind of therapy. And obviously, these are well selected and centralized data from expert centers, but this is a restage HF trial outcomes which could demonstrate in young patients up to almost 50% explant rate in this cohort up to 36 months. And if you take a look after the explant, so the Kaplan-Meier figure shows that the survival without the need for new LVAD implant or transplant was more than 77% at 3 years, which is definitely something which is worth to be considered in younger patient population. And if we project this survival curve even longer, so these are data published by Stavros Drakos from the VADVIN International Registry, which show that the survival after the weaning of the LVAD is right on the survival of the patients after the transplant from the ISHLT registry. So in other words, so by promoting recovery in LVAD patients, we can provide them with the equivalent survival as with the transplant later on. So, and with all that in mind, I strongly believe that we should be compelled to systematically screen and kind of modify our decision-making process since the very beginning, pre-implant, to identify the phenotypes with a heightened risk for heightened potential for recovery, followed by the GDMT on LVAD therapy, systematic and programmatic identification of partial or full responders based on the LV dimensions and ejection fraction, explant, and ultimately the long-term follow-up to provide these patients with special care and GDMT long-term monitoring. So to put it to the nutshell, so we can say that median survival with the heart transplantation as is now is around 12 years. The probability of receiving a second transplant is 4 to 6% in multiple registries, but probably in some geographies it's even less. While the median survival with the LVAD in patients younger than 50 years is over 7 years. So with that in mind, it seems pretty reasonable to consider the LVAD as the first-line therapy in patients with expected long waiting times based on the body dimensions, for instance, or heart PRAs, but also taking into consideration the availability of the transplant in any given geography worldwide. So in the patients with a favorable HeartMate-3 LVAD survival scores, in younger patients in a quest towards the net prolongation life and also the recovery and some other specific relative contraindications to transplants as shown here in this figure. So to move one step further down the road, let me move from young patients to middle age and older patients. And this is hot off the press. It has been just presented last week, and I appreciate that Uriel could share this data, which had been presented at ES Heart Failure last week in Barcelona. So, and because there is still uncertainty for middle-aged and older patients with advanced heart failure, what is the optimal strategy for this particular age group? So, and for this reason, the data from the Momentum-3 and CAT cohort has been used and compared and contrasted to the UNOS data from the United States for these two subpopulations, age 50 to 64 and over 65 population. So, and as shown here, so the data have been matched and for this particular age group, so it appeared that the survival was better for transplant, and the same was for the age of over 65. However, again, using the same algorithm or approach of comparing the patient's survival since the time of listing for transplant or for the LVAD therapy. So it has appeared that the HeartMate-3 survival was in reality higher than for patients who have been transplanted for this particular age group and for the patients older than 65 years of age. So there was a numerical trend in favor of the HeartMate-3 once again. However, it has not reached statistical significance yet. And once again, let me zoom in to some specific complications. There was definitely less infection requiring hospitalization in patients who have been implanted with the HeartMate-3. And there was no difference in this age group between the prevalence of stroke. And for the older patient population, so the same effect of less infection was observed. However, there was already dissociation in terms of strokes, which was favoring transplant, which may has to do very much with the underlying comorbidities of this older patient population. So, and last but not least, on this topic, let me mention frailty. And these are very fresh data which we have published at the ISHLT at Toronto on the analysis of the frailty in patients as we have pulled the data from the Momentum 3 and the ARES trial as shown here. And we sought to characterize the prevalence and severity of the frailty by using standardized measurements to examine the association between the frailty and post-implant outcomes, and also assess longitudinal changes in frailty and their impact following the LVAD implantation. And the data were very interesting, as I will show you in a minute. So we have used the Rockwood cumulative deficit approach, which is a multifactorial index encompassing 41 parameters, as shown here, and which divides the patients into 3 cohorts: mild, moderate, and severely frail cohort, as shown here. So here is a distribution from our cohort analysis. And on the right-hand side, you can appreciate that there is very poor correlation between the age and the severity of frailty. So subconsciously, we may feel that the older patients are more frail, but we could not corroborate on this at all in this robust data set. And there is clear association between the frailty and the outcomes. The primary composite endpoint, very clear. Also, all-cause mortality. And the same relates to the hemocompatibility-related adverse events. So the more frail, the higher incidence of adverse events in this respect, as shown here. So what is important from this observation is that frailty is a modifiable risk factor. So, and you can appreciate that for all 3 subsets of patients with different stage of frailty, so there was a significant improvement which could have been achieved for all subsets. So, which is very important, and we have to entertain further initiatives to identify these patients who may benefit and who may have a good chance to be recovered from this initial frailty at the time of the implantation. And further to this point, if we divide the patients between those who have recovered in terms of their frailty over time to those who have not, so it's very clear that there was significant improvement in the primary endpoint, and the same has been also demonstrated for the various subsets of patients in different cohorts which have recovered or not recovered. So, and these are very important observations, and this analysis could also identify some predictors of recovery from frailty. So basically, these were negative predictors. So the history of atrial fibrillation, prior CABG or PCI, duration of heart failure more than 1 year, higher body mass index, or history of diabetes were negative predictive factors in terms of the recovery from the initial frailty at the time of the LVAD implantation. So, and after, this tsunami of Kaplan-Meier curves for the surgical society. So now let me transition to something probably more entertaining for the surgical audience, and let me spend the second part on some considerations regarding surgical aspects. So the conventional implant procedure is obviously the implantation via sternotomy, but more and more are entertained less invasive approaches, whether it be combination with upper hemisternotomy or double anterior thoracotomy, as shown here in these patients. So, and there is an ongoing debate for a decade or more. So, which approach is better or superior? So, we have no conclusive answer yet, and it's more a question of belief than the hard evidence. But at least what we can state from the HeartMate 3 SWIFT trial, which used the data of the patients from the Momentum 3 and the CAP. So there is absolutely no difference in the outcomes in terms of the survival, event-free survival, or even disabling stroke. So, which basically can be translated that there is established second standard for the HeartMate-3 implantation by less invasive implantation. So now let me move forward to those who cannot be addressed with the LVAD alone. So, and still the HeartMate-3 has the opportunity to help these patients. And here you can appreciate the 2A recommendation by European guidelines, and there are some descriptive parameters which are indicative of the higher risk of RD failure post LVAD implantation, as shown here. So PAPI is one of those very popular in recent era. So, and with that in mind, so there are multiple ways how to address this issue. And if you take a look to the right, so this is probably the most commonly used technique of the biventricular HeartMate-3 implant with the implantation to the right atrium of the right-sided pump towards the pulmonary artery. And I'm extremely excited to mention, and I will come to this topic in a minute, that this therapy, despite all the potential drawbacks of non-dedicated, biventricular device, are pretty positive. So, as an example, so these are data from Australia of BIVET support patients, and despite the fact that 50% have been transplanted up to 2 years, so it clearly shows excellent survival up to 2 years, which is basically in the matter of fact very positive that these patients can do well while appropriately selected. So, and I'm also very, very excited to share this hot of the press article. I was very privileged to collaborate with a group of Professor Khalil from Riyadh on the quest of robotic BIVET implantations, which spare the sternum for the subsequent heart transplantation, and which is very, very seminal work in this field. And I'm glad to acknowledge that Professor Khalil did the other robotic BIVET transplant just today to celebrate our meeting proudly. So, and moving from the BIVET support to something even more critical to the patients who may require total artificial heart, in other words, the replacement or removal of their native hearts. So these are the indications: ventricular thrombosis, restrictive etiologies, cardiac tumors, refractory arrhythmias, or fulminant rejection after heart transplantation typically. So these patients can be also managed by using 2 HeartMate-3 pumps as shown here. And there are definitely some potential advantages of this approach, as the full magnetic levitation provides very proper and stable positioning, even in lower speed, in a milieu of pulmonary circulation, higher degree of thromboresistance. Yet there are some drawbacks, as mentioned. Doubled peripherals represent a hindrance. There is an absence of automated interplay between 2 of these pumps, and adhesions and need for silicone spacers in the prospect of subsequent transplantation is also of a concern. So this is one of our patients implanted at Prague. So it was patient after mastered correction of transposition of great arteries. So this is interposited graft to the PA, so which was highly or largely dilated. So, and this is the final position because she has been on the previous HeartMate-3. So we made it up to HeartMate-9. However, obviously, just 2 pumps were operational, and the last one was left in place instead of the silicone expander. So this is shortly after the implant, and now I'm pleased to say that the patient is almost 2.5 years on this support and doing incredibly well. So let me mention some dimensional considerations in LVAD implantations. Will the body size allow for proper placement of the LVAD pump? The second question, heart size and anatomy, will allow for diameter perspective, LVDD perspective, or underlying congenital or other anatomy for the safe implantation of the device. And the third question is related to the heart pathology itself. So whether systolic or diastolic dysfunction will allow for proper filling of the LVAD. So and with that in mind, so we try to explore more and more the boundaries of 3D rendering prior to the implant to be very precise in the planning of the procedure. So, and this is a software we are using. So we collaborate with group of from Hungary, from Budapest. So and this 3D rendering software may allow us to perfectly and precisely pre-plan each individual implantation, any conflict with the rib cage, any specific anatomies, namely in the patients with congenital heart disease, etc. So, and this is definitely something what we can discuss later in our presentation down the road. So, one more issue which we are facing is the contraindication for the implantation of the device from the apex, as shown here. So this is severely calcified apex. So, and here are some anatomical contraindications: small LVs, LV aneurysms, apical calcifications, or restrictive type of physiology. And there are also some extra cardiac anatomical considerations, such as small rib cage conflict, especially in pediatric or smaller BSA patients. So in this respect, so we try to utilize the alternative approach of the left atrial cannulation with the graft which is sutured to the interatrial septum, and the pump sits on the free wall of the right atrium, similar to the RVAD. So, and in smaller patient population, especially in pediatric population, so we are even more precise with any potential pre-planning. And these are pictures from our colleagues from Shumakov Institute. And this is one of the smallest implanted pediatric patients, 5 years, 14-kilo boy. So, and definitely there was no way how to implant the pump given the conflict with cage. However, this simulation allowed for the implantation of the intraatrial conduit as shown here. So, and this is the final position in this very minute patient rib cage. So what is the next on the horizon? So there are multiple devices which are under development or already in clinical trials used in most of our geographies. And let me just mention a few innovations which need to be introduced to the field. So definitely a fully internalized system should be a game changer. So, and we are talking about it more for more than 1 or 2 decades. So the devices which will be tailored to the specific patient cohorts, smart pumping algorithms, real data transmission, which will allow integration of artificial intelligence in terms of prediction of adverse events, using sensors and combining it with clinical data. So after all these positive, messages, I try to convey to this distinguished audience. So let me just highlight one important point. Since 2022, the HeartMate 3 device, the LVAD, is in 1A class, the strongest ever class of recommendation across the societies. However, if you take a look to the actual numbers of implants, so they are at best at the plateau. So this is American registry. Nonetheless, the same is probably translated to most of the global geographies. So, and so we, and the point is that we seem, as we look to the Rogers bell curve, stuck in the chasm. So the limited confidence, usability, and compatibility with routine practice is shown here. So where are the LVADs? So we could not breach the barrier of utilizing these devices in early adopters only, unlike other technologies or therapies such as TAVR, for instance. So, and that having in mind, so we are stuck in a self-reinforcing equilibrium of LVADs as a last resort therapy, as shown here. So with the persuasion gap, a lack of meaningful and easy triggers, delayed referrals, high perceived risk of the therapy itself. So which comes to the point of low volume and experience and limited knowledge growth and closing the loop with the misalignment with the industry and insufficient funding for the innovation in this space. So, the message is very clear. So we have in our hands the pump, which is very powerful with very elegant profile of adverse events and long durability. And we can do a lot by standardizing the practices. So these are the data from the Momentum 3 trial, and you can see how disparate were the outcomes in terms of mortality across 50 centers which have been included, and the same accounts for the distribution of very excellent and less excellent centers of the centers which have been included in the trial. So, and this is important message that we can do a lot with the pump we have available today, and not to wait till the innovation of tomorrow. So to put it to conclude, let me mention that we have to start do better in standardization, try to identify more rigorous triggers for referral and evaluation of the patients. So we have to establish and work more on regionalized LVAD networks, hub and spoke centers concept. We have to align better with reimbursement, bundle payment, and dynamic cost effectiveness. Embrace more patient, clinician, and industry to speak the same language as one team, and to allow us as physicians and clinicians to co-design with the industry the next generation devices along with the public engagement. So with that in mind, let me leave you with several inferences. The current LVADs represented by the HeartMate 3 is a mature, safe, and life-prolonging therapy. Clinical comfort in selective decision-making towards net prolongation life of net prolongation life and recovery pursuits is evident, and I think that we have first-time data in our hands to be more selective in that. So further to the point, there is importance of accounting for a real-world pathway in comparing heart replacement strategies, whether it be LVAD or heart transplantation, especially in the geographies where the availability of the heart transplant is fairly low. Advanced surgical techniques and 3D pre-planning in addressing challenging phenotypes is definitely the way to improve the outcomes. The technological advancements are in progress as documented. However, accelerated and catalyzed needs to be accelerated and catalyzed by the broader diffusion of currently available LVAD therapy in a collective and most structured manner. Thank you very much for your attention.
Thank you very much, Professor. This is a beautiful lecture. We've learned a lot, and this is quite a lecture. Thank you very much. We'll start with the panelist questions. If there is a question, please go ahead.
If you allow me, first, Professor Nituka, thank you very much for this thorough review. Honestly, there are a few points that is going to help us and the clinical practitioners in order to identify first the patients who are in need of advanced surgical therapy, doing the intermax, applying intermax on models on these patients, because what we see in our cohort, at least here in Saudi Arabia, is the patient coming really way too late. For example, last year we did 10 BiVAD versus only 8 LVAD solo. And that tells you how bad it is. And the 10 BiVAD were durable BiVAD. The non-durable BiVAD, we did 18. So this tells you 2/3 of the patients are receiving, if not more, are receiving a BiVAD support, which is really sad. That means the general practitioners, the general cardiologists, are not referring it early enough for the advanced heart failure cardiologist, who is also not referring the patient early enough to the surgeon. for whether bridge transplant or to transplant. So I believe that RV failure remain a major fact. And for you to know, the patient who was sent, you mentioned that today we operated another robotic BiVAD. We did, and the patient was sent for robotic LVAD solo, and he had cardiomems. And over the weekend, for non-sustained VTAC, he deteriorated, and the uresis didn't go through. And of course, with his high RA pressures and higher wedge with lower PAPI, he went into severe RV failure. Now, my question to you is a provocative one. So you've mentioned in one of the clinical trials is the age between 50 and 65. And then you mentioned the age 65 and beyond, the comparison between heart transplants and LVAD. Though it did not show any significant statistic significance between both, but there is a trend of better LVAD, as you mentioned. Now, the question here to come is, how long have these patients been supported on the LVAD, knowing that beyond 2 years, you start to have raised rate of driveline infection, raised rate of admission due to RV failure. Thrombosis is sort of outside the spectrum, but these patients come with comorbidity where they do stroke as well. So I want to challenge this theory, because despite that it proves our efficiency of the pump, it can send a message to the audience that they can just start doing LVAD right and left, even for non-transplanted centers. So your thought on that matter? Thank you.
Thank you. It's absolutely great point. I think, and I mentioned it in my presentation, these two therapies are complementary. And to find a sweet spot when to shift from one to the other one, so it's very delicate. And we are at the beginning of this understanding of this issue. This is the first point. My take is that as long as the patient on the LVAD therapy is free of complications and the factors, as you mentioned, such as progressive RV failure, so they can stay on this therapy. So once they start developing, and we should have cardiomems and other things, to be able to identify these additional risk factors. So then we should switch gears toward the transplantation in this category of older or middle-aged category of patients. This is what I can say. So I understand, and I know from my experience that the issue of driveline infection is one of the limiting points for the long-term support with the LVAD. So we can do a lot nowadays with better prevention, and patient care of the driveline. So, but ultimately, the solution will be the driveline-less system. So this is what I can state to that. And one more comment to this. So you refer to the US data, and I definitely agree that we have to be more region specific and even ethnicity specific, because there are some underlying abnormalities in hemocompatibility, etc. So and even for the future of the AI. So we have to stay more regionalized in collecting these data, because something what worked for the US did not work for Ireland national model, predictive score. So this is something what we have to take into consideration and not to adopt these implications blindly.
Ivan, thank you very much for the great talk. I'd like to have your opinion on, in the last 2 years, we've shifted gear from not taking patients in Intermax 1 to the operating room, where most of the time either you end with an LVAD and temporary RVAD or a BiVAD. And the last 26 patients we've done in the last 2 years, using the Impella ECMO, weaning the ECMO, keeping the patient Impella for a week until everything works well, then proceed with an LVAD. And we've seen a marked decrease in the use of a temporary RVAD or a BiVAD. What is your practice in that result?
Thank you, Riyad. I very much agree and support this approach of either the impella first and then stabilizing the patient and conditioning the patient for the definitive durable heart-rate 3 implantation. So this is what we do. So if we are with the ecpella, initially we try to de-escalate, switch to the impella alone support, and then transition these patients towards the durable therapy. So there was a lot of enthusiasm about the Impella 5.5, so I'm enthusiastic too. However, I would like to exercise some caution here regarding the strokes, which are an issue. So basically, my point is that dragging way too long on the provisional Impella therapy in patients who are not at imminent risk of recovery, creates additional risk for the durable LVAD implant. So I think that these therapies are again complementary, but we should take a good sequence of steps towards the long-term therapy. But definitely agree that we can eliminate some of these patients who would have been otherwise supported biventricularly. Agree.
Thanks.
Great. If you may, I ask you, Professor Nutukev, about selecting sometimes to do patient on the temporary RVAD during LVAD. Is there any way that you could tell us in quick notes on who is the patient that we should put them on this? Apart from the parameters, they come and tell you that the echo, the RV is okay, you could get away with just LVAD, and sudden of all, you just see him in the ICU. His lactate is lingering. He's not doing the best. So what's your thoughts on this one? Early initiation RVAD versus just LVAD and walk it out.
Well, I personally, and I presented at the SHLT that we have to consider the RVAD support as something negative and refer it as a complication. So it's in the best interest of the patients while well-selected patient population is the subject to this strategy. So that's why we have pretty low threshold for at least using a short-term RVAD support with Sentimag typically. And should there not be sufficient recovery in a reasonable time frame, I'm referring to 2 weeks. So then we transition towards the durable RVAD from thoracotomy approach. So for this reason, we keep a little bit more loose the prosthesis on the PA to allow us to suture, from the thoracotomy approach, the original prosthetic graft to the inflow graft of the durable RVAD. So I think that we have to conceptually change this model that we should shy away of the RVAD. Of course, not for everyone. So we have parameters which have been listed: PAPI, CVP, LVDD to RVDD ratio, CVP to PC wedge, and others. And importantly enough, so in patients who are in prolonged RV failure, so it's probably smarter to pursue with a durable BiVAD implant as a first line option. In those who may have just deteriorated recently, so it's probably reasonable to give them a try and try it on the temporary RVAD to figure out what's going to happen.
So your preferred method is to just put an RVAD, support him for a while, and it's not necessarily to be considered as a failure or one of the parameters.
I absolutely don't consider the RVAD implant. I consider a failure, a delayed.
Exactly.
RVAD implant, but well thought out RVAD implant is something very positive for the trajectory of the patient.
Awesome. You're muted, Firas. Prof. Firas.
Thank you. As a matter of fact, a lot of publication for the past 7-8 years that was released mentioning that the mortality increases drastically if you do a staged RVAD rather than simultaneous in the operative room. So pre-operative planning for whether you need an RVAD or not is essential. My question to you, Ivan, again, for your opinion and prospect in regards to Abbott, still keeping the RVAD HeartMate 3 as an off-label. We have enough patients who has been operated. And you've mentioned the Australian group, they had it up to 2 years. In King Faisal, we had it up to 6 years BIVAD support. And now we have a lot of them on BIVAD over 2 years awaiting for surgery. Yet they're stable. The reason I'm raising this up, because we do have referral for patients who are having good LV function, severe mitral stenosis, and severe RV dysfunction, severe RV dilatation due to severe tricuspid regurgitation, with pulmonary pressures reaching systemic almost. These patients become inoperable. You know, with severe TR and severe MS and severe pulmonary hypertension and severe RV dysfunction, they tend to go on ECMO post-bypass, and most of the time you cannot really wean them. Why shouldn't we book these as a normal cases of going in, replacing the mitral, repairing the tricuspid, and or just really leaving the tricuspid, but implanting an RVAD? What's your thought on that?
I think it's very pertinent approach. So you mentioned the point of being off-label, which is definitely from the regulatory perspective and maybe even reimbursement perspective a hurdle. Nonetheless, I think that it's a matter of time that Abbott and the other players in the field of LVAD will act on that. So there are some other manufacturers who are providing already a bundled BIVAD system with a single driveline, and single peripherals. And I think definitely this is the way to go. And I can only encourage Abbott to do the same, because they have brilliant pumps, and we can build out more out of it, by being integrated as a singular platform. So there is a question from the audience: how to improve the referral system for heart failure patients in the higher centers in Saudi Arabia? As mentioned, many patients reach the advanced stage in peripheral centers. So I do have experience from Saudi, but I don't claim myself to be an expert on Saudi healthcare system, of course. So maybe you can probably make much more reasonable comments, at least both of you from Saudi guys. But I think it's again, as I mentioned, this pyramid. It's multifactorial, and we have to start transmitting not a negative but positive message. Stop talking about the complication, but speaking more positively about the advantages and long-term benefits of the therapy. So this is the goal.
I totally agree. I think it's multifactorial. The cardiology is very well connected in not only in Saudi Arabia, but in the Gulf states. And there are PUT system, referral system. For Saudi Arabia, it's called Sahati. And you can refer to MOH. You can refer to King Faisal. For us, I'm speaking of our hospital. My advice is refer to definitely centralization for the heart failure. So refer to a high volume heart failure program. That's number one. And if you couldn't get a response quickly, then pick up the phone and speak one of the cardiologists in the department, or you speak to the chairman of the department. And they will be happily accepting to look at the case and discuss it. But the formal official way is through Sahati referral. And for accelerative manner, you just pick up the phone or text a message to one of the cardiologists or cardiac surgeon from a high volume center. They will respond to you immediately with accepting the case. I think this is a very important question, honestly, because a lot of people still have some confusion in the matter of reaching out to different hospitals. There are 3 transplant programs in the kingdom. They all happen to be in Riyadh. So one of these transplant programs are, I'm sure, ready to receive the patient and be transferred to them. They have a very advanced heart failure program as well, in order to take care of the patient, whether he needs just simply advanced heart failure medical management versus advanced surgical management. And always, every single patient has to be offered transplant. And while waiting, if it takes longer time, depends on the blood group, it depends on PSAs or the resistance and antibodies presence or comorbidities, then they go to a VAD program. And for the VAD program, they have to be backed up and supported by a heart transplant program for a reason that we have mentioned of complication that might rise and put someone, a program who's non-heart transplant program, in a bound, such as the RV failure, such as the driveline infection that is resistant to multiple debridement, such as to malignant arrhythmias that happens even despite the presence of an LVAD. So all these are indication for that. But nevertheless, you could, whoever asks the questions, and this is for everyone, you can reach out to the high volume transplant programs. Dr. Tarazi, Dr. Othman, your opinions?
I think it's fair enough. What has been said, centralization, it's the best thing for the patient outcomes. And I believe in these ideas. But sometimes the access to care is another big issue, and the geography for the patients and the referral and all of that things. So it is a bit complicated, as Ivan says. It is quite dynamic and complicated, but what we say is we keep doing those webinars. We keep reaching out to the heart failure physicians, to the heart failure doctors, and to the cardiologist in general, who sees the patients, and we tell them those are the channels to access the care for your patient, and those are the current results or the real world results. It's much better now. People more educated, more aware of this, and all of those is available everywhere. So it's a pretty complicated one, and I think it is everywhere in the world.
Yes, I definitely agree. Just to mention one point you mentioned, and I want to underscore it. So centralization is a good thing. So, but you deal with long distances, and probably interpositing a telemonitoring, whether it be CardioMEMS, for instance, sets a common platform between the referring cardiologist, who is not losing the patient, but you already get into control of the patient, and you can end up with a shared decision-making process in optimizing the point of basically starting the next level of advanced therapy. So, and this is something which should be integrated to this scenario, number one. And number two, it creates additional spirit of collaborative spirit between the referring cardiologist, even from the distance, that he's not losing the patient and you are starting to share the patient. Right. And you are very active in Saudi. So whether it be within the Team HF trial, which is randomizing these patients for the telemonitoring with the CardioMEMS, or outside of that. So I think that you are very progressive, and this is definitely the way to go.
Right. Thank you. There is 2 questions from the audience. One of them, in your opinion, do you think direct oral anticoagulation, such as apixaban, could become standard alternative to warfarin?
The simple answer is probably yes. We don't have the conclusive answer unless we conduct and complete the randomized trial. So which will bring up the definitive answer. But it's very promising, and at least at this time point, I think that we can say that in patients with some contraindication, whether it be absolute or relative to standard of care warfarin anticoagulation, so this can be safely managed with the apixaban, basically given the high degree of thromboresistance of the HeartMate 3, while addressing only the ambient sources of potential thromboembolism.
Awesome. Second question is, in patient with the LVAD who developed recurrent bleeding or suspect heparin HIT, what's the alternative anticoagulation strategy do you currently favor, and how do you monitor the efficacy of the pump thrombosis and risk? So the first part is for the HIT patients or who have recurrent bleeding. How would you manage those patients?
HIT patients with heparin-induced thrombocytopenia?
Yeah.
No, so we manage them with argatroban. So that's, and if needed, we withdraw for a limited period of time completely anticoagulation if needed. So,
Right.
so to this point, I would like to mention, and I think that my colleagues are well familiar with that. So we are pretty aggressive, for instance, in patients with AFib to clip the appendages, just to limit the major source of embolism in case we have to withdraw anticoagulation in AFib patients, for instance. So these are some preventative measures.
Very
Ivan,
nice.
in patients with the sustained VTAC that we operate on, sometimes we get patients where you put ECMO Impella and he's continuously VTACing and shocking, and we had the patient who shocked 60 times. And then we send to the cath lab for ablation endocardially. If you take him to the operating room, what epicardial ablation strategy do you do in these patients?
Thank you. This is absolutely a great point. In our practice, we have great EP guys, great team, but we combine these forces. And at the time of these patients, coming to the OR, we perform non-selective epicardial ablation, which helps a lot because it cannot be reached later on after the implant, of course. So we create a circle at the level of the apical cuff with the cryo probe, and then basically perpendicularly,
parallel to the coronaries.
We create one parallel to the LAD, the other, and all the way to the base of the LA appendage, and the other one on the lateral and posterior wall. So which help them to address it later on if there is some residual endocardial lesion to be addressed. So non-selective circle and 1, 2, 3, 4 lines all the way to the AV groove. The cryoprobe, the AtriCure one, so the regular one.
As a matter of fact, it helped. I remember I had few of these patients, and I asked you, Ivan, and it did help a lot for these sustained VTAC. So Riyadh, it does work well when you just
we tried it once, but it didn't help. I mean, it wasn't that great, because it's a poor man's way of ablating. I mean, you don't know what you're doing from the outside.
Of course, but it's better than nothing. So sometimes these patients are really aggressive, having aggressive arrhythmias. Where I remember one of our patients who stayed on the BiVAD HeartMate 6 for 4 years. This patient, for 2 years, he was having ventricular fibrillation, and he was living normally because he had the both support, which we always, advocate for ventricular rhythm, of course. But some of them, they make it, even with these malignant arrhythmias, if they are on BiVAD, of course, not on NVAD solo. Yeah.
Okay. There's a couple of other questions.
If we can conclude
yeah,
to a
sure.
last question, that would
the
be
last
awesome.
question is, do you request doing PET scan pre-LVAD implantation to rule out cancers? I don't think so.
In patients with cancer or to rule out cancer?
Metastasis, maybe he means.
In patients with current, well, if it is a patient with existing cancer, then the answer would be yes. But as a screening procedure, we don't do that. So we do a routine cancer screening, in all patients, of course, X-ray, maybe CT scan is reasonable, and gastroscopy, colonoscopy, so and abdominal echo. So, but not PET scan.
Awesome. Well, at the end of the of this, we would like to thank you all for the great and excellent webinar, and very looking forward to see you again in another webinars. If there is any questions or concerns from audience, please send it to us, and we'll look into that. Thank you, Professor Natuka. Thank you, Professor Tarzi. Thank you, Professor Khalil.
Thank you.
Thank you. I think our next webinar is going to be in November.
Great. Looking
Awesome.
forward. Thank you very
Thanks
much.
very much.
Thank you, everyone.
Good evening.
Thanks a lot.
Bye-bye.